Yeah, good afternoon, all. I welcome all India doctors and paramedical staff for this Orofer FCM Prerna Scientific Educational Webinar. I'm Nakul Patil, Senior Product Manager. We at Emcure, we are the purpose-driven organization and dedicated towards the offering effective medicine to cure the patients and enable to healthy living. That Orofer FCM is our core brand, an epitome of quality and success. We at Emcure, we has helped around more than 60 lakh Indian patients to rapidly correct the iron deficiency anemia. And furthermore, we are taking a pledge for making India iron strong. Today, you and Emcure is honored to have esteemed speaker, Dr. Nikita Lad. Dr. Nikita Lad, she is a renowned gynecologist and IVF specialist, IVF and fertility specialist from Mumbai. Her special area of interest are the high-risk obstetric practice as well as infertility, definitely in hysterolaparoscopic surgery. We are thankful to Dr. Nikita Lad for giving us opportunity to host this scientific webinar. And very important that be a partner for this wonderful academic initiative, educational initiative. Today, Dr. Nikita Lad sharing her views on and further guiding on administration of FCM with the right dose, dilution, and duration. And very importantly, that happy to share with share that I could see from across India more than 8,000 paramedical staff they have logged in, and further they are going to listening this scientific webinar. Once again, I welcome Dr. Nikita, and over to you, Doctor.
Thank you, Nakul, for the introduction. And I'm glad to partner for such a major thing called anemia. 50 to 52% of our population is anemic. Patients entering my clinic, always when we do a CBC, we hardly see anybody having a 12 hemoglobin. Very rare. And in pregnancy, especially because, why in pregnancy, the volume of the blood increases. That's the reason the hemoglobin concentration, RBCs, are always down. Whatever nutrition you tell the patients or whatever, you have to give iron substitute tablets. And as we all know, sometimes patients have issues with iron tablets. They have, retching, their stools are dark, sometimes constipation, even with the newer tablets. Not every female can handle the oral tablets. We have to have something IV. Before, remember, we used to give an IM injectable. I remember about 20 years back, which was so painful to the patients. They used to have abscesses on their buttocks. Since then, when the IV started, and we are so lucky, even in the government hospitals, when I was in Sion Hospital working, post-delivery, even if she had little bit of bleeding, we do not need to give blood transfusion anymore. Like before, blood transfusion was the main thing. So now with an iron FCM, which I'm sure most of y'all are using, we just need to know rightly how to use it, know the dilution, what we have to prevent, precautions, and what all drugs we need to keep around when we give an FCM injections. So what is anemia? Is an iron deficiency in pregnancy. So our hemoglobin is low. That is the oxygen carrying capacity of the blood decreasing. So that is the reason we do not want in pregnancy, we do not want any patient to have an low hemoglobin. Specifically, WHO says not less than 10. For Indian specifically, otherwise it's an 11 gram. But in Indian with, a rural population, we have to at least try minimum 10 grams. So put the patients always on oral, keep monitoring their CBC values when they come in the first time itself. And if you feel, no, now my patient needs to be given an IV FCM, it's very safe. There are no side effects, but we need to always be precaution of everything. Even one drug can cause any reaction. So it's not about we don't have to have fears, but we should always be prepared for everything. So otherwise the patient's going to say, why, you had not been prepared. So this patient's doctors do give it on an OPD basis. Yes, why not? But keep an Efcorlin, Avil, injectables next to you if required. Half an hour at least you have to keep the patient after even giving the IV FCM. Then let them go back. So first, when they come in, please take the vitals like SpO2, pulse, BP, make them sleep, lie down, tell them what you're going to do. So now, depending upon the hemoglobin, if a hemoglobin is extremely low, 6, 7, you've decided to give an 750 or a 1 gram. So it depends. There are three. There's a 500 mg, 750, and a 1 gram. Which one you want to give, you can repeat it after a week, depending upon a hemoglobin. So if you've given a 750 or a 1 gram, I would take a 250 ml normal saline bottle. I would take a 250 ml. In that, I would add, if it's 750 or a 1 gram for both, it is 250 ml. And I will take about 15 minutes for it to go, not longer. See, most of the staff, all the doctors say, okay, give it slow, give it within 2 hours, put a micro drip. So, you all are used to that. But these injectables do not take longer than 15 minutes. Yes, if your doctor says, try a test dose, first, maybe 30 seconds, you can go little slow, check there are no reactions. There are no, on the injectable side, there's no redness, there is no itching, there is no tightness of breath. If these things are not there, you can start the dose, increase it and give it in 15 minutes. You have to stop it. You know how thick the solution gets once you put the FCM inside the normal saline. So you cannot let it go over a longer duration of time. And if you're just giving a 500, you will not take a 250 ml, you take a 100 ml normal saline and you will finish off within 9 to 10 minutes, not more than that. Okay, so this is the basic things. First, you come, let the patient come, vitals are checked, put the vein flow or whatever angiocath you're putting, start, you make sure the air is out. After the air is out, you will put it inside the hands. Make sure that within first 30 seconds, maybe let it go slow. Doesn't matter. After 30 seconds, 9 minutes, the whole dilution, the whole FCM should be over. You will see the difference. Patients, most of them after an FCM will give you, even the old people who are lacking, deficiency or even cancer patients who need to take iron, you'll see the difference. They feel good. They say, oh, my thinking power increased. I'm feeling better. What is the reason? These things are because your oxygen capacity is increasing to the brain everywhere. So the person feels a feeling of well-being. So that is the reason after an FCM, patients feel good. Sometimes some patients come 2 weekly, 3 weekly. They tell us, maybe my hemoglobin is low. I'm feeling weak. You can give it, but you have to calculate. Just do not give it. If the hemoglobin is more than 12, 13, we do not give. Post-surgeries, yes. Sometimes post-delivery, I mostly give my patients because I don't want to take a chance because I know she's going to be breastfeeding. Her diet will maybe not be taken care of. During a normal delivery, the bleeding is always there. So we have to prevent, we know how to go about. So if your doctor says, give the injectable, like I said, remember the main things, the dilution, which is the normal saline is what are you going to use is normal saline 100 or 250 ml. 100 is for 500, 750 and 1 is 250 ml. 9 minutes and 9 to 10 minutes and 15 minutes, it should be over it. I would love to even take any questions if the staff has, because, we should know and we should be prepared. Like I said, whatever any mishaps are done, because you as staff, you all are the main person always next to the patient. You are the first person on the go. Doctors might just prescribe and they might go away, but you are sitting there. So you should be knowing what to give, what to do, because at that moment itself, if you inject an Avil or Efcorlin, if a patient saying, I'm feeling breathless, stop. Do not continue. Don't say, let me wait for another 2 minutes. You can just stop the drip. You can just call the doctor. What is it? Take her pulse BP. See if the rashes are coming. Is she feeling still breathless? And then later, maybe you can say, not this time. I will check next time. So instead of 750, we can start with a 500 the next time. So these are the things you should be remembered and you should know these things. Any questions?
Yes, doctor. Just I'm checking inbox. There is one question, doctor. That question from Chandigarh. One of my doctor is using 500 mg in 250 ns in 30 minutes and using with the same protocol without any adverse effect. Is he doing right or means wrong?
The actual indication and the protocol, maybe he's not wrong, he's not got any reaction, but always remember we have some things because we've done evidence studies. Emcure has done the studies on lots of patients. That's how they've come with this dilution method. So I would still say if he's taking 250 ml, you can even have a word. I attended a Emcure's professional training program, and they did tell us that give it within 10 minutes in a 100 ml normal saline. So that is a better, safer way. Yes, I know some doctors do feel, that I better dilute it more and, the reaction will not be there, but that's not the case. So it's better if you're giving 5K, you give it in a 100 ml normal saline and within 9 to 10 minutes.
Right, doctor, right. Well, means we want to understand what for paramedical staff, what precautions need to take while giving FCM.
So like I said, the timing, dilution, you got it. But remember, if the patient complains, you have to see most of the time, even you as nursing staff know anything you're giving, you will wait there for about 5 minutes. Even an IV antibiotics have given a major reactions to patients. Suddenly you will see there's no pulse or suddenly she doesn't speak. Even a basic antibiotic next to me or MZ injections have given these reactions. So I always tell my nurse staff that you should have an Efcorlin, Avil, adrenaline next to you. It should always be there with some, not loaded, but it should be around on the table when you're injectable. If you are giving in the OPD, still you can keep these injections. You don't have oxygen and all, but at least these basic 3 drugs should be around when you're injecting. Even an OPD setup can have this. So I think we should make sure, and why we don't want patients to have anemia, because you might see patients coming at a 7th month with a preterm delivery. Suddenly they come and deliver at a 6-7 months. We can avoid this by just making sure their hemoglobin is normal. In rural areas, sometimes patients don't take iron tablets. They will come to the hospital first time at, when they miss the period, maybe after 2 months or 3 months, and then directly during delivery. Or just at a 7th month they come. So, we can't do anything else, but we have to administer IV to make sure. And I would say I must have administered thousands of patients with FCM. Touch wood, till now I have not had any reaction. So, at least one thing is taken care of. We know, but like I said, I always make sure my paramedic staff knows what to do. But reactions are not very common. Just be prepared for the worst.
Yeah, absolutely. The administration of FCM, the awareness is very important. How to means dose dilution, that's very important in routine practice. And when suppose any patient got ADR, so what means as a paramedical staff, what precautions they need to take?
For what?
For suppose any patients they are getting ADR, so as a paramedical staff, what precautions they need to take?
If they're getting anaphylaxis reaction,
yes.
Anaphylaxis, you have to give an Avil Efcorlin injection. That's the only way you can save anything.
Do they need to stop the infusion?
Yes. They need to stop the infusion that moment itself. Do not continue at all and just give these injectables and wait with her. But do not continue. Any reaction, remember, any drug, stop. That is the main first thing. Do not continue the drug. We don't know what caused the reactions. Maybe the drug had something, or the dilution was wrong, or you were giving very slow. I've seen sometimes, one of my staff nurse was giving it to my receptionist. And it went on. She suddenly called me after an hour. I'm feeling very tight. I'm like, how come it's going on till now? You should have been finished in 15 minutes. She said, no, the staff nurse told me give it slow for an hour. So in that cases, I've seen, if you go slow and you go for a longer duration, I have seen a lot of reactions. So that is the time patients will complain of little difficulty in breathing and breathlessness and chest and discomfort in the chest. So please, like I said, the timing is very important.
Over duration and the over dilution.
Both are wrong.
So as the guideline says, the minimum concentration should be 2 milligram per ml.
Yes.
So can they directly give without any dilution also?
No, I have never seen. I don't know. What would you say? Because I have never given without dilution. I've always given.
Some doctors are giving, and as a PI is also saying we can give, but as you know, precaution is always better. Better to dilute in the specific 100 and 250 ml.
See, sometimes there can be reaction when you're injecting IV also, because these drugs need to be diluted. I feel it needs a way to go. The medium has to be the normal saline, I think.
Yeah. Okay.
Yeah, doctor, one question. Before administration of FCM, means test dose required or not?
So like, how we give test dose in antibiotics and all, we give little bit of that. So I tell my nurse to give about for 30 seconds, let it go slow. Within the first 30 seconds, you see it will come in 30 seconds itself if there's any reaction. So wait for the first 30 seconds, any rash is coming out, or she's saying, I'm feeling some blebs come on the hand, red color, or she says, I can't breathe, or you can see face is suddenly turning, swelling up, stop it. So I would say test dose in a way, actually FCM does not require a test dose. They say you don't need it, but I always tell better to take precautions. First 30 seconds, go slow, and then if there's nothing, she doesn't complain, go on.
So those patients who have a history of respiratory hypersensitivity reactions or antibiotic hypersensitivity reaction, so those patients, are they prone for having the same anaphylaxis for FCM?
I have not yet. I have not seen in my, I have asthmatic patients coming in. So they already have ARDS. I have injected in those patients also. Cardiac patients come to us. But like I said, if my patient has complained on an IV antibiotic reaction, I'm always careful. So I'm more preventive. Like I would say the doctor should stand. If she had a previous history of any reaction with the staff, I think a doctor should wait there for the first 5-7 minutes that, the patient is fine, and then you should go. Because any previous history of a reaction, yes, you have a little bit of chance of any reaction to any drug. So preventively, a staff, like I said, with all these drugs should be there with the doctor.
So this is not related to this question is not related to dose duration dilution, but how to treat a severe type of anemia in first trimester?
See, first trimester, I don't give FCM at all. So, I don't know. Do you all recommend FCM in first trimester?
No.
We never give FCM in first trimester. I always see if it's very severe, like a 4 hemoglobin, I have to give a PT, blood transfusion. There is no other choice. And if it is between 9 to 10, I can wait on the oral drugs, and it will take its own time if she can. Some patients who do not tolerate oral, I try to give them syrup. Like a 10, some patients will tolerate syrup. Iron is a very tough, when some patients have issues, they're just not ready to take. Mera previous pregnancy, I had the worst time taking the tablets. I had belching, my stools were dark. When they don't want to take, they're ready to take one IV, but they will not take the oral tablets. Then we tell them, see, in mild but severe, blood transfusion is the only packed cell volume, not a direct blood transfusion. PCV is the main thing. But we cannot have the hemoglobin low, not less than 10 for sure. So everybody should make sure the hemoglobin, we all check, I think you all have even these Emcures come with the, small, even in the rural areas, they go just checking the hemoglobin. And I think you all have the non-touch machine, the new one. I think you guys have come with that.
Yes, we are both non-music.
That was really good, So sometimes they come to our OPD, which is busy on a Saturday. They do everybody's, and then whoever's is less, they send them inside. So that's a very good machine, which, at least without, patients are also happy, not painful. They're like, just hold it there. And within, I think, few seconds, you get the hemoglobin levels. Yeah. And it's quite specific. So I did check it with the other machine just to, know. Because in Apollo, I think every Saturday, the Emcure people sits and they do hemoglobin levels. So, but severe, yes, a packed cell, PCV should be the main treatment. And when you're doing as a staff, how scary a blood transfusion is. Forget the FCM we are talking about. Here, we are more worried in a blood transfusion reactions. And before only we give Avil, Efcodlin, before you start a blood transfusion.
Okay. There might be chances of infections also.
And anaphylaxis reaction. Yeah. Yes, both of them. Infections, luckily now, because of the testing and, HIV, HBS, HCV are tested quite well regular. So that has gone down drastically since 20 years before. That is all taken care. But anaphylaxis, I've seen bad anaphylaxis with blood transfusions.
Even after cross-matching and all, everything.
Yes, that's really, and those are really fearful. So these, I think it's a boon with such injectables that we don't let a patient go till 4 or 5 hemoglobin now. But we are living in a country which is developing, yet we see a lot of people, like I said, 50% of our population will have low hemoglobin. How much ever Indian, the government is trying to, go everywhere in rural area, give hemoglobin tablets. You see, every iron tablet is given free, calcium is given free in government hospitals. Going to houses people give nowadays. Still there's so much of iron deficiency. Because maybe the diet is poor, malabsorption, not only iron deficiency, there's megaloblastic anemia, there's thalassemia. So whenever, like you said, when there is severe anemia, first find out what is the cause.
is the cause.
Actually iron deficiency, is it thalassemia, what is the cause, and treat it accordingly. Just an iron tablet and IV or blood transfusion will just help you that moment, but till you don't find out the cause and treat it, we are not treating the patient.
So related to this thing, what dietary advice the paramedical staff can advise to the patient after giving the FCM? As you says, the protein is also important, vitamin B12, B9 is also important. So what dietary advice they can advise to the patient?
See, like, spinach, beetroot, they say singdana ki chikki, because singdana sing with good. Most of the government hospital like Sion and KEM give this in the OPDs. They'll be giving patients with singdana and good while they're sitting in the OPD itself.
Yeah, most of PMC hospitals do.
Yes,
Yeah,
all the
even Indian government of India as a Anemia Mukta Bharat, they recommended iron-rich food. That's very important.
So spinach, I would say, make sure they have a spinach soup or add a lot of salads with colors like capsicum, green, red, yellow, carrots, baby corn. Add spinach soup with beetroot. I tell them to add both. And whenever they're hungry in mid snacks, I tell them to have like singdana ki chikki. Like when I was in Sion hospital, I used to see them giving all these to these pregnant patients. I'm telling you, nothing like India. I've studied in UK, gone to US, nothing. I'm telling, we really take care of our people. Just because of our population, we cannot handle. Otherwise, our government does a wonderful job. And I think we should just push all our patients to make sure they eat healthy. See, sometimes I understand in rural, they don't have the money or they're delivering again and again. They delivered within another.
Food taboos are also there.
Yes.
Cannot eat papaya, that thing.
So that is the thing. And they deliver again, multiple pregnancies. Now she's conceived. Contraception, we explain them, we talk to them, but still within a year, if they come, where's the hemoglobin going to develop? She's breastfeeding the patient and baby, and she's already pregnant. So she's already going to have these deficiencies. So when, as a staff nurse or paramedic staff, you have to talk about contraception. That is also very important. You are the first person next to them. You're discussing things. Talk to them. What do you want to do? There's, nowadays we do postpartum COPD. So post-delivery only we put the COPD and come out. So, they don't have to come next time. Even after LSCS or even after the delivery, naturally, we put the COPD and send them. So these are the things we should, as a staff, they will listen to you. You can talk to them. As doctors, we make this effort every time. But you can tell them, because oral contraceptive pills we cannot give. And it's better to be avoided because she's breastfeeding. Yeah. So, and within 6 weeks, again, she can get pregnant. And I've seen so many times in 2 months, the lady is pregnant and she thought she's breastfeeding. And the doctor locally said, oh, you're breastfeeding. That's why you not got your period. Suddenly at 4th, 5th month, she comes. So it is so sad for her also. And, she must have visited the doctor around, but, sometimes it's just missed and they think it's because of breastfeeding, amenorrhea, and we don't want to, miss out these things. So I think contraception has to be spoken by y'all, and that will be an important thing which you're going to help future. Even if you leave 2 or 3 females listen to you and put a COPD, that's going to help a lot of people.
What's the minimum gap of years should be there between
I always say at least 2 years to 3 years.
2 years, yeah.
2 years minimum, that they have, the body has generated all the nutrition, whatever was gone during delivery and breastfeeding. That's the right time, because most of them breastfeed for 1.5 years sometimes.
Correct.
Do you prefer vitamin B12 supplementation along with the FCM?
Sometimes, yes, I do give. They have deficiencies of B12. So I check their blood levels and then I decide what to be given. So if they have B6, B12 really low, or, their D3s also. Nowadays, if you do in pregnancy, B6, B12, D3 are very low. So
ma'am, what is your recommended dose, ma'am? Either it is 500, 750 or 1K in your clinical practice.
I have to give if there was minimal 9 or 8, I would give 500 and I would repeat after a or 2 weeks. That was the thing. Now with 750 coming in, I think I would be more happier. Instead of giving the 500 or repeating, I would give 750 and wait and see how she's growing. In milder case, I think 1 dose of 750 will be good.
And ma'am, how will we, means there are literature, if we give the FCM along with that, we should give the vitamin B12 supplementation so that there will be the better absorption. So is it true, ma'am?
Yes, I totally agree, because sometimes I've seen that with them, with the hemoglobin levels are low, B6, B12 are low. So what I do, I give them Bitcofol injections too. On their buttocks, when they've come, only when the IV is going on, I give them the Bitcofol, and one vial of Bitcofol, I think 5 doses you can give them. And I'm telling you, they are sorted for at least till our delivery. Everything is taken care of. Even if you know that she's not going to have PPH or preterm delivery, at least we can prevent all these things. This is what we can do to avoid anemia and to prevent any of the complications related to anemia. One PPH, a little bit of bleeding when the hemoglobin is 8 grams, even my patient loses hardly something, but you see the tachycardia, the BP drops. It's so stressful on the patient and as a doctor. So I would always recommend, make sure your patient's hemoglobin is more than 10 grams. Do not let it go less than 10 for sure.
Yeah, ma'am, one question. How do you calculate the dose of FCM in your clinical practice? Means as per the weight, HB chart, or Ganassi formula? Which you prefer?
You all have, I think you all had given us one dose, calculating with when starting. But now with time, I kind of know when this 9 to 8 to 9, I'm going to give 750, or when it is. So I don't know whether you all still tell your doctors about this calculation chart or no.
Yes. We are giving poster, and this is the right time. Means we are circulating all posters to means in clinics.
So what is your calculation chart? Can you tell me? Because I basically, on my clinical level judgment, I make sure that I give, when it is 9, I give about 500 gram and I repeat it after a week. So what is your calculation?
That's the same only. Means we divided a group that that's the body weight we divided. And as per the body weight, if suppose patient is less than 10, HB is less than 10, so we are recommending 500. That's the cumulative dose is they require 500. If patient body weight is around 35 to 70 kg and hemoglobin less than 10, so we are recommending 750. Means 750 must be, that is divided into two doses. For on first day 750, and after 7 days that's a 750. Yeah, that's a calculation as per the body weight.
Okay, so I think it's the same what we clinically judgment is. So same way. But I think you all had one good chart, which we used to multiply. I think at the beginning stage when FCM that time they used to give this chart. But now I think clinically all the doctors know how much to give. Now we have got used to. And anyway, we repeat the hemoglobin after 3 weeks, 21 days I wait always. I don't think repeating after a week or 2 weeks does make sense. Have patience. Otherwise patients also say, "Arey, IV diya, abhi tak bada kyun nahi?" Okay. So I tell the patients also, and I think as even the doctors should know, we should have patience. Hold on, it is going to increase. So sometimes even when I'm giving vitamin C also helps in absorption, like you were talking about, B6, B12. Even vitamin C gives you very good absorption of iron. So if you even give, nowadays a lot of doctors give a lot of IV vitamin C's too. For just good, feel good factor. There are so many clinics which give IV vitamin C's that will improve your, immunity, improve every, of sense of well-being in patients. Mostly they give D3 IV, but on deep IM, and they give a vitamin C IV shot, like glutathiones, like, cosmetic people give a lot of glutathione for good skin. So they add vitamin C to it. So there's I think they give 3-4 ampules of vitamin C directly with the glutathione. So it not only your skin, your hair, but, they don't realize why it happens, why vitamin C helps, because it helps in absorption of iron. That's the main way the action of vitamin C is.
Ma'am, do you prefer the estimating the ferritin levels, ma'am, in the iron deficiency patient? Yes. So how it will be, ma'am? Means what will be the level and how you go ahead for the treatment with the same?
The ferritin is low. I don't have the range now, but every lab will have a different range. Look at it. Yes. But if ferritin is low and iron is also in the normal range, I give. You have to give. So look at the ferritin level. That's an important point.
Less than 30 is a less than
30 microgram. Less than 30 microgram.
Yeah, less than 30 you give. Don't wait for the hemoglobin. So you see, sometimes hemoglobin you'll see is normal.
Okay.
And the ferritin is low. You give an IV. Abroad in US and all, they don't only look at hemoglobin. There, most of the hemoglobin is normal. They look at the ferritin level, which is very important. I don't know whether Indian doctors do that, but ferritin level is low. If you just in 500, not even 750 you'll need in these patients. A 500 will, they feel good. Everything is, oxygen carrying capacity in your body will improve. The infections decrease. So everything, so ferritin level is important. So while reading the CBC, you ask for an ferritin, and if it is low, please give it.
Right. Ma'am, happy to share with you that more than 10,000 paramedical staff, they have logged in, and then all they are listening to you.
I'm glad we can be helpful.
Yeah.
And, good Emcure took such an initiative, because I think these are the basic things which we are talking. Maybe it will help them also,
Ma'am, they are eager to listen. What is the administration of FCM? Can you repeat again?
Okay, so like I said, remember when the patient walks in, first you're going to check their vitals, check their blood pressure, take their pulse, take the weight, and then let them rest, and then take the angiocath and start, depending if you're giving 500, 750 or 1K. If it is 500, you're going to give 100 ml normal saline. 100 ml normal saline, you add the 5K and then give it first 30 seconds slow and finish off within 9 to 10 minutes. Do not wait longer. Remember, everybody wants to give fast. Do not go fast. Don't go slow. People think 1 ghante mein jana chahiye. No. 500 will go within 9 to 10 minutes. Now 750 and 1K, you will take a 250 ml normal saline. In a 250 ml normal saline, go first again 30 seconds slow and finish it off within 15 minutes. Finish it off within 15 minutes. Don't wait longer. This is the right way. They have studied. Evidence is shown. There's no reaction. And it is, how even I at the starting, I was asking these people, why should I go fast? Even I thought there'll be some reaction. I was also terrified at the beginning. I totally understand, because, we always go slow. You will see any IV, we are going slow. We do not try to go fast. But in this case, evidence is done, studies are done. Anaphylaxis is the least if you give it in this timing. So 9 minutes, 15 minutes, 100 ml for 5K, 750 and 1K, you will do it in 15 minutes. Anything else? Basically, if any staff
monitor the patient for at least 30 minutes after giving tips.
Don't send them away. That is again, sometimes they come back with breathlessness. So that is one thing. Even if you're doing, some doctors do give it in the OPD. I totally understand. It's okay. But keep them for about half an hour. We are protecting ourselves and protecting the patient too. So, it's better to take. Okay, one person had asked me about the consent. So one of the doctors, a GP, had asked me that, I'm going to give this. Should I take a consent? Because, there can be anaphylaxis reaction. So because I had written and the patient was staying far away. So he was scared to give, or he was really anxious. First time he was giving. So I said, you can talk to him, or you want to write down. There can be reaction. See, sometimes nowadays, because of lot of, complaints and anything can happen to a patient, at least talk. If you want, just write 2 lines that I'm giving IV administration. What is the reason? Why am I giving? And sometimes people can have anaphylaxis reaction, and just take a sign, fitness sign, and give them, administer.
Right.
Ma'am?
Yes.
Very good evening, ma'am. Just an offbeat question from one of your discussion points. So earlier, just you mentioned that every pregnant lady has to take calcium and vitamins as a supplements. So my just question is that what is the ideal dose? I would not say ideal, but what amount of vitamin D or vitamin B is suitable for a pregnant lady?
See, nowadays calcium already has. They might be having, 200, depends upon whatever it is, which calcium you are having. Sometimes a it depends upon whichever you are giving them with them, they'll have that ingredient. But if sometimes their D3 levels, I see 4 and 5, in that I give them an injectable 1 shot, Arachidol 66K, 6 lakh units. And after that, I maybe put them, if it's a very low dose, I might put them per weekly also on the Arachidol 60,000 sachet. I don't only wait for the calcium with an D3 to take care of her deficiency state. Because nowadays in pregnancy, I've seen, sometimes the patient comes crying. We feel it is hormonal. Because of the pregnancy, the hormones are changing. But I see a lot of them with D3, 4 and 5. Because they are not going out. Pregnancy, most of the people say stay in the house. So in that case, please look at the D3 first. I feel D3 gives them a lot of depression and mood swings. So like I said, if it's very low, give an injectable, put them on sachet, and then calcium with a D3, whatever, 100, 200 is enough. And that will take care in the future continuously. But give them a higher dose at the beginning. Multivitamins, with an only iron tablet, I'm happy. If the B6, B12 is good, I just don't add too many medicines. See, there's a lot of side effects. Like I have gone through 2 pregnancies. I know how tough it is to take even multivitamins. So how you feel, just an iron, calcium, and a protein is enough according to me. No more of extra B6, B12 or anything. If they're deficient, yes. Otherwise, look in the blood work. Just don't prescribe medicines to patients. That is one thing I would say, avoid. See, I give all my patients only iron, 1 calcium and protein. That's the only supplement. And I tell them nutrition-wise, eat well. After
the
the
first trimester or second trimester?
First trimester, only folic acid I give, nothing else. No iron, no calcium. Most of them, if they are in 10 gram plus, let it be. Tell them to eat well and all, because first trimester, they're throwing up so much. And in that you add an iron, this is very tough on them. Yeah. So first trimester, only simple folic acid is one thing which I continue. If they have too much of nausea, add a doxynate or something. But otherwise, I just give plain folic acid. After the 12th week, I will add. Otherwise, if they complain in 9th, 11th week, leg pain, tiredness, then I see the CBCs coming low, then I add an iron tablet by around 11 to 12 weeks. Iron, I continue once a day. Some patients, they do, I'm sure they're not taking it well, or add different 2 salts. Sometimes they say, I'm getting belching with this. I try another salt. And if at least one of them they'll be taking. So now the ascorbate, the newer salts have coming in so many. And whichever one suits a patient, this is what you have to give the patient. And I think, like you asked me about multivitamins, I would say avoid. If they're not required, do not give these micronutrients. I don't think there's any difference. And patients, if you're asking about the low class patients, they will not even buy it. I feel the cheaper way, whatever the cheapest iron tablet, which is going to help her increase the iron, is the main thing what we need to help them out.
Correct. And thank you very much, ma'am, for this clarity. And ma'am, is there any time duration after 7 weeks or 11 weeks or 15 weeks? You have to start with this calcium therapy or iron therapy. Like in iron therapy, we say we are not giving in first trimester any kind of iron. So is there anything like this related to calcium therapy or this vitamin D3 therapy or something like this?
I avoid everything in first trimester most of the time. I don't give anything except folic acid. See, most of the time they don't complain also. Only the nausea is there.
Calcitriol is contraindicated in first trimester. So small amount of vitamin D3 can convert in calcitriol in first trimester. So that the fetal development mostly happen in first trimester. So we avoid basically. Second trimester, in first trimester only folic acid.
Hi, Dr. Pence. I could say it was a wonderful session and many insights we have got. Hope all paramedical staff clearly understood about the right dose, dilution and duration of FCM. And I really thanks to Dr. Nikita Lad for giving us time and giving us this opportunity to host this Orofer FCM Prerna scientific webinar. Thank you. Thank you very much, Doctor. Thanks for your time.
Thank you, Emcure, and I hope everybody. We try to decrease anemia in our country. That will be the greatest thing. We are still at 50%. It's a long way to go, but let's try it.
Correct.
Thank you, guys. Thank you.
Thank you so much.
Thank you, Doctor.
Thank you so much, ma'am.
Thank you, Dr. Nishikant, Dr. Kaveri, Dr. Mr. Aditya, and thank you very much, Ankit.
Yeah, thank you.
Yeah,
thank you so much, ma'am.
Yeah, Ankit, can you stop recording? Yeah.
Recording stopped.
Ma'am, really thanks.
Thank
you. It
was
a really wonderful session.
That's good.
It's a lot of insight we have got, Doctor.
Yes, and even I hope it really helps our staff. That will be great. Thank you.
Yes. We'll share the highlights.
Conversation is really help because one-way conversation better to have
That's why I asked him, you want me to talk about the PPT, because I know that nobody talks. It's always better, we have a conversation like a round table.
Yeah.
All right. Thank you.
Yeah. Thank you, Doctor. Thank you very much. Yeah. Dr. Kaveri.